I would like to welcome everyone to today's webinar presentation, Navigating Discussions of Prognosis, Balancing Honesty with Hope. I'm Lynn Osborne, Director of Business Development at the Schwartz Center for Compassionate Healthcare, and your moderator for today's session. The Schwartz Center for Compassionate Healthcare is a national nonprofit organization dedicated to strengthening the relationship between patients and their clinical caregivers and preserving the human connection in healthcare. Before we begin the formal presentation, let's go over a few details about the webinar. The Schwartz Center Compassion in Action webinar series is funded in part by a donation in memory of Julian and Eunice Cohen. Today's program will be 60 minutes. The first 45 minutes will be presentation, followed by a 10-minute question and answer session. Today's program is being recorded and will be available on the Schwartz Center website a week after the session. Please note that attendees are participating in listening-only mode, but can interact with the speakers and me by using the questions pane, which should be appearing on your screen. If you have questions, please just type them into the questions pane and send them to us, and we will address as many of them as we can at the end of the formal program. We'll also be polling the audience during the session, and we hope you will participate in this tool. As you exit the webinar, you'll receive an electronic survey that we ask you to take a minute to complete so that we may measure your assessment of today's program. Your feedback is really important to us. And now it is my pleasure to introduce our host for today's session, Dr. Beth Lown. Beth is an associate professor of medicine at Harvard Medical School and the medical director of the Schwartz Center for Compassionate Healthcare. Beth?
Thank you, Lynn, and good afternoon, everyone. In today's webinar, I'm just delighted to welcome Vicki Jackson, one of my own teachers, a cherished teacher, a wonderful teacher. She's going to address the myths and some of the barriers associated with communicating challenging information to patients. And she'll present a cognitive model for prognostic disclosure. We hope that today's session will help you gain a deeper understanding of the research supporting the different communication strategies for discussing difficult content and addressing patient and caregiver emotions. And it is my pleasure now to introduce today's speaker, Dr. Vicki Jackson. Vicki is Chief of the Palliative Care Division at Massachusetts General Hospital and of the former fellowship in the Harvard Palliative Medicine Fellowship. She's the former fellowship director. Vicki completed residency and chief residency in internal medicine at the Cambridge Hospital, which is a Harvard Medical School teaching affiliate. She has pursued training and research methods through the Harvard General Medicine Fellowship and completed a master's in public health at the Harvard School of Public Health. She also completed training in palliative care at the Dana-Farber Cancer Institute and the Brigham and Women's Hospital. Currently, Vicki is the palliative care lead investigator for a grant funded by the National Institutes of Health investigating the effect of early ambulatory palliative care for patients with advanced cancer. Her work focuses on developing curricula to train others in the communication skills required to deliver this care. And she spends much of her time developing, teaching, and evaluating palliative medicine curricula for medical students, residents, fellows, and faculty. So welcome, Vicki. We're just delighted to have you with us.
Thank you so much, Beth. I'm really pleased to be here and so excited to be part of the Schwartz Center and all of the great work that you do.
Thank you so much, Vicki.
Thank you. I'm really excited today to be talking about this topic because I think it's one that challenges many of us about how do we think about balancing honesty and hope when we're talking to patients who have serious illness. I have no financial disclosures to report, and I have a few learning objectives for us today. One is to appreciate the benefits of discussing prognosis in patients who have serious illness. A second objective is to describe the myths about and barriers to discussing prognosis. And finally, to apply a cognitive model for discussing prognosis with patients. I think it's important to just describe a bit about palliative care for those of you who may be less familiar with palliative care, because part of what I'm going to be describing today is really grounded in my practice, what I do every day. And palliative care is a specialized kind of medical care for patients with serious illness. This type of care is focused on providing patients with relief from certain symptoms, pain, the stress of illness, whatever the diagnosis or prognosis. And we talk about it as being an extra layer of support to the patient's other clinicians. And on slide 8, you'll see that, traditionally there was a model of care for patients with serious illness that went something like, we'll continue with life-prolonging care until at some arbitrary point, represented by the dark vertical line, where on the day before the vertical line you were living and getting life-prolonging care, and some arbitrary day after, we think you're dying. And that's when we institute palliative care and hospice care. And it was quite fragmented for patients, and patients often would feel abandoned by their primary treating team. And I think on slide 9, what you'll find is that this is a model that we think about in terms of bringing primary palliative care skills that should be implemented early on in the course of serious illness. And these primary palliative care skills should be skills that any clinician can employ with their patient, not necessarily subspecialty level palliative care that I might provide having done a fellowship, but any patient who's seeing their oncologist should be able to have some of these conversations with their oncologist. And we see these sort of primary palliative care skills being implemented at the time of diagnosis while patients are getting disease-modifying therapy, and that these palliative care components may become a larger part of the care of the patient as they become closer to the end of their life. But this is not a binary sort of interaction, not yesterday you were living and today you're dying, but actually that this is much more of a continuum. And that part of what we have to do is think about how do we talk about hope and the honest dialogue about progression of illness in the context of this kind of illness trajectory. So the way we think about helping patients talk about this illness trajectory is a concept we talk about, this concept of prognostic awareness, helping patients cultivate prognostic awareness. And we've put made some of these references available to you on the website as well, to the links to these references. And when I talk about prognostic awareness, I mean the patient's capacity to understand his or her prognosis and the likely illness trajectory, right? Because I think we've all been with patients when we've heard a clinician, or we may have even given the patient information, and we really feel like we may have said it, they may have heard it, they may have even been able to repeat it back to us, but they haven't really integrated it. And that understanding this, cultivating this awareness, this prognostic awareness, is something that is a process that happens over time. And that's part of our job for patients with serious illness. And I think the reason we want to help patients cultivate this prognostic awareness is because it's helpful to them, right? It helps them with making informed, shared decisions. So patients with more information can do a better job of matching decisions about medical treatment with their personal goals and values. They can do a better job of weighing burdens and benefits of treatment, and they can prepare themselves and their loved ones for the future. I think part of what we see when there's a big push to think about how can we do a better job with advanced care planning. But the reality is, I think we see and experience that it can be quite challenging. And many primary care clinicians will say to me, I find it really difficult. I try to talk to my patients about this, but I don't feel like they really understand. And what clinicians will say to me is that I feel like I have an understanding of their illness and what's going to happen, but they don't really understand what I think living with this Parkinson's disease is going to look like, or their heart failure. And how can we really plan together when they've really never seen what their life, have an idea of what life is going to look like with this illness? And I think so the question is, how can we help patients gain a deeper understanding and help them be able to use that in an informed way to help them, help us be able to do a better job with them with making these decisions and help with the advanced care planning decision making. So this diagram is sort of the way I conceptualize having advanced care planning discussions. So on slide 13 here, you'll see that I see this top circle on the left is that the patient has a realm of expertise, and they're expert in their goals and values, right? So they can say, the thing that's most important to me is being able to be with my family, or the thing that's most important to me is to be able to play golf. I had a patient who said to me, if I can't play golf 3 times a week, life isn't worth living to me. Okay, that's pretty important for me to know, right? The clinician, we're expert, we need to be expert in prognosis, and what do we expect is going to likely really be the prognosis with this illness, and the medical options that are available. And in this universe of choice, what are all of the options that are available? And then, do we think that they actually would be a reasonable choice for this patient, right? That doesn't mean that every single option that's out there that we would want to, that we think we can't, just because we can use it doesn't mean we should use it, right? So I had a clinician recently who said to me, there was a patient of his who was 95 who came in who was having some cardiac ischemia, and they were asking about doing a stent procedure. And he said, I was really worried about it. He said, I thought she had a 100% chance of dying if I didn't do it, and a 95% chance of dying if she did it. And I said, wow, well, that's pretty amazing, right? And I said, what was her chance of dying if you did it or not in the next 2 months? And he said, 100%, right? And so part of what we talked through was maybe in that situation, the recommendation, because this woman didn't want to be in the hospital, that was her goal and value, was although it technically could be done, his sense was he should make a recommendation not to do it, right? Because although technically it could be done, it wasn't in keeping with her goals and values. So the next part in the advanced care planning discussion is taking what we know is in this clinician expertise realm up here on the right, is to actually synthesize the goals, patient goals and values, and what we know are medical options, and make a recommendation. As I'm saying with this cardiologist, he realized this patient said, I don't want to spend time in the hospital. Being able to, even if I had some chance of being able to have a little more time, it wasn't worth it because I know overall time is quite short for me. And he decided to make a recommendation against having another medical intervention. So I think some of this is, if we're going to help patients do good advanced care planning, we actually have to be able to help that cardiologist talk to this patient about the fact that we think time is quite short for her. Otherwise, she can't really make a decision about these medical treatments. So how can we help clinicians think about how to talk about prognosis in a way that balances what we know about the illness and hope? So part of, I think, the things that help us when we think about having these discussions is knowing what is it that patients with serious illness really want. Because I think one of the pitfalls is, clinicians always say patients just want to live longer. That's what they want. They want to live longer at all costs. But in reality, what we know from the literature is patients want more than that. And we know that patients with serious illness want several things. And this was a nice study done several years ago by Singer that was published in JAMA. And it was a study of hundreds of patients with serious illness, and a survey of sort of the things that were important to them. And there were several things that patients said were important to them. Relief of pain and other symptoms. They really were concerned about being a burden on their family. They wanted to achieve a sense of control. They wanted assistance strengthening relationships with loved ones. And they wanted help with informed shared medical decision-making and with the medical care team. And they wanted to avoid inappropriate, unwanted prolongation of the dying process. And we'll go through these together. So I would suggest that helping patients cultivate a deeper prognostic awareness can help relieve the burdens on the families. And let's talk about that, how that can be true. So serious illness can be financially and psychologically difficult for families, and I think it's really important for us to remember this, is that in families who have a loved one with serious illness, in 20%, a family member has to quit work or has to make a major life change to provide care to a patient. And over a third have lost most or part of the family savings. So it is a huge impact on patients and families. And that's from the support study. Alexi Wright has done work with the Coping with Cancer study, which has actually shown that the place of death actually has a big impact on the patient and the family's end of life, the family's bereavement actually. So death in the ICU, so patients who died in the ICU, their family had a 5-time increased risk of PTSD. So I think it's a really important thing for us to think about how the burden that the serious illness has on the patient's family and how we can be of help in this. So also, how can we help these patients sort of achieve a sense of control? So, you know, what we know, this is also from the support study. Jane Weeks found that provision of prognostic information changes care, and several studies have shown this as well. And she found that patients who expected a 6-month survival were 2.5 times more likely to choose and receive life-extending therapy. Now, these patients didn't live any longer. They didn't survive any longer, but they were more likely to choose therapy that they thought would extend their life, like more aggressive care. And if they had an understanding that they had just a 10% chance of dying in 6 months, it led to less aggressive treatment decisions. So people just have to have some sense that they could die. They don't have to know that they're going to die, just some sense that it's possible. I think it also is true that this advanced care planning can help patients achieve a sense of control. You know, patients report wanting to know treatment preferences. They want us to know their treatment preferences, and they also report wanting to be prepared for death. You know, multiple studies show nobody wants to talk about this, but they also want to be prepared and not to be shocked, right? So that becomes the tricky piece when we're talking with patients about these issues. So this is a very powerful, powerful slide in my mind. A colleague of mine here, Eva Chittenden, was a hospitalist at UCSF, and she was doing a palliative care consultation and went in to see a man who had a COPD exacerbation in the ICU. And she went in and introduced herself to the patient, and she was being consulted to help with goals of care. And she said to the patient, "Hi, I'm a palliative care doctor. They've come to help with medical decision making. How can I be of help to you?" And he grabbed a piece of paper and he wrote, "Let me go." And I think we will have failed as a medical system if the first time we are trying to have a discussion with the patient is when they have lost their voice and their ability to speak, right? The question is, can we figure out a way as a health system to be having this discussion when a patient is cognitively intact, not on a ventilator, and able to actually express their wishes more fully? So how can we help them strengthen relationships with loved ones, and how can prognostic awareness help with that? I think what we know is that patients who, the families of patients who are hospitalized, unfortunately, in the hospital, it is a hard place for families to be, right? It is being in our academic medical centers, even in large community hospitals. It can feel like a place where there is not very much support, not very much shared medical decision making. This was a study from Joan Tino that was published in JAG several years ago. Families can feel like they don't have information about what to expect and not a lot of respectful treatment. And so I think the more we can help patients and their families understand what to expect early on, the more support their families are going to feel navigating this serious illness over time. And then finally, let's think about how patients with prognostic awareness, how this actually can help with shared medical decision making along with the medical care team. So this is also from Alexi Wright from the Coping with Cancer study. So this was a study, a multi-site longitudinal study of 332 patient family dyads who had advanced cancer. And they asked, do you remember having a discussion with your oncologist about what would happen if you got sicker from your cancer and we weren't able to cure your cancer, basically? And what was really interesting is a little over a third of patients reported having a discussion about prognosis. And what was interesting, we don't know anything about the quality of these discussions, about the content, about the length of them, just that it made an impression on the patient and that they remembered. And the patients who remembered having these discussions were a different patient population than the rest, right? This patient population had lower rates of ventilation, lower rates of resuscitation, and ICU enrollment, and earlier hospice enrollment. So having these conversations correlate with different outcomes. I think, and this is something that we've been very interested in here at MGH, really trying to think about, are there ways for us to think about improving the care for patients with serious illness? And a lot of our research has been really looking at early intervention palliative care. You know, we started this early with a feasibility study with Jennifer Temmel, actually, when she was an oncology fellow back in 2002, 2003, and then the early intervention work that we published in 2010, and we're just finishing up recruitment now for a repeat early intervention study that we're hoping to be able to understand more deeply what's happening in this early intervention model. I'm going to go a little bit more deeply into the findings that what we found in the early intervention study to try to think that through a little bit and how it's related to prognostic awareness. In our early intervention study, we had 151 patients, and we were comparing that patients would either get standard oncology care plus referral to early palliative care at the time of diagnosis, or just standard oncology care, and the oncologist could refer to us whenever they chose, but it was when they decided, not early at the time of diagnosis. And for the intervention group, we saw them monthly. And our primary outcome was quality of life, and our secondary outcome was mood and other end-of-life outcomes. And we found there were several outcomes that were really interesting. One was that quality of life was improved at 12 weeks in the early intervention group, which I was glad about because, frankly, this is my job, so I was quite happy that the quality of life was improved in the patients who were seeing early palliative care, so that was good. I would say the finding that I am most proud of is the fact that patients who received early palliative care, that group had a 50% lower rate of depression. So, the piece is that part of what we were doing this entire time in this study was helping patients understand and helping them cultivate prognostic awareness. And if part of the thing that we're talking about with patients, the reason we're worried about having these discussions that people say is, oh, well, they're going to give up and they're going to die sooner and they're going to be depressed. Well, that was certainly not borne out in this study, right? I think typically, patients would say to me things like, so wait a second, Vicki, let me get this straight. So you'll tell me when I should worry, and until then, I'm just going to live and have fun. And I'd say, that sounds great. That sounds like a great plan. You go have fun and live your life. And then if I'm getting worried about what's happening with your cancer, we'll talk about that together. Okay, that sounds like a plan. Now, you'll see on slide 29 here, the reason that this study got a lot of press was because the patients who received early palliative care had a prolonged survival. They lived nearly 3 months longer than the patients who received standard oncology care. You know, and the reason we looked at survival at all, frankly, was because we just wanted to make sure that people were living at least the same amount of time as the patients who were getting standard oncology care, right? We wanted to make sure that any critic who would say, oh, see, they are just getting less chemotherapy because of you people, and what if they're not living as long? So we were not expecting that there would be a prolonged survival. But I think that there's something about, you know, will we see this in our follow-up study? I think we have no idea. It's a very different time. Oncology care is different. I think we don't know if we'll see a prolonged survival. But I think the key piece is talking about these things does not make people depressed and give up and die. That, I think, I can say with confidence. So let's talk a little bit about, again, why we think we want to have patients have prognostic awareness, because we think that they're going to engage more fully in medical decision-making. We want them to have more meaningful discussion, and we think they make different treatment decisions. There's a little clip of interaction that I have with a patient that we will post that you're welcome to look at, which is just an interesting exploration of a patient and his understanding of his prognosis that I'd encourage you to look at, and realizing that, you know, you don't have to actually make a prognostic disclosure to be able to have a fairly deep discussion with a patient about their prognosis. Okay, so let's think a little bit about, if we know that it's better for patients, why don't we do it? So I would say we don't do it because we're worried about several things. We're worried we're going to take away hope. I forever have clinicians tell me we're going to make them be hopeless and give up and die. I also have patients or clinicians say to me, well, we're forever inaccurate and only God knows. I have clinicians say that to me all the time. Another thing is, you know, patients don't really want to know this stuff. They say they do, but they don't really want to know. And another thing is, clinicians, I think, really worry that it'll take too much time, because these are difficult conversations and they don't want to mess them up. So let's take these myths one at a time. So a promotion of prognostic awareness takes away hope. I think the truth is, talking about prognostic awareness, prognosis is hard, but I don't think it takes away hope. What I think we know from the literature, and I think is really supported by the study, our study that I just showed, is that patients and families want to talk about prognosis. It does help with decision making. It's not associated, as far as we can tell, with more worry or depression. There is data that there's better bereavement adjustment for family members, and there is some data that hope can be increased or at least preserved with these kinds of serious discussions. It really just needs to be done in a way that is there is a skill, just like any other medical. It's sort of a medical procedure, and we just need to do it skillfully. Okay, let's take the next myth. We don't ever really know prognosis, so we can't talk about it. So I would say the truth is there is prognostic uncertainty. We can't get around that. We need to find a way to talk about it. Okay, we've got our first polling question here. So our first polling question here, is everybody ready for this? Is, do physicians over or underestimate prognosis? So you get to select one. Do we over or underestimate prognosis? What do you think? Because, you know, everybody says we're wrong. So in which way are we off? Are we overly optimistic or less optimistic? What do you think? Okay, I think we've got a pretty good response rate. Let's go to our results here. Okay, we have our results show 66% of you say that we overestimate and 34% say we overestimate. Okay. All right. And in fact, we do overestimate. And let's go to our second polling question here. Now, by what factor do you think we overestimate patient prognoses? So, I mean, do we overestimate by a factor of 2, by a factor of 3, by a factor of 4, or a factor of 5? What do you think? By what factor do we overestimate patient prognoses? Because, you know, we definitely overestimate, but how much do we overestimate? Okay, looks like we've got some good results. What do we think here? So our polling results here, it looks like 29% of us think that we overestimate by a factor of 2. 43% of us think we overestimate by a factor of 3. 13% think we overestimate by a factor of 4. And 15% think we overestimate by a factor of 5. Okay, well, let us go to Nicholas Christakis' data here, who he actually, from his study, has shown us that physicians overestimate survival by a factor of 5.3, which I think for most of us is fairly shocking. So I always say, if you think a patient's going to live 5 months, divide by 5. It's probably more like a month, right? And why do we do that? Is it because we're really so terrible? No, it's because we care about the patient, right? The other thing that was interesting from Nicholas's data is as the duration of the physician-patient relationship increases and time since last contact decreases, prognostic accuracy decreases, okay? So for the primary care clinicians in the room, if you've been caring for somebody for 15 or 20 years, maybe it's more like a factor of 10, okay? Because we know them and we care about them and we know their children and we know their grandchildren. The other, the other piece that I think is interesting from Nicholas is that the more you practice with a certain group, the better you are. So I am very good at prognosticating for patients with lung cancer and tumors in their pancreas. Not as great with patients with breast cancer because I just don't see as many patients with breast cancer. So it's just a very important thing to be aware of, that we're going to be wrong, but we have to figure out a way to talk about the prognostic uncertainty. That's not a reason not to talk about it. Okay, let's take the next myth. No one ever really wants to know their prognosis. So I would say the truth is patients do want to know, but it is hard to talk about. Absolutely true. Okay, so this is a study published several years ago in JCO, and this was a study of patients and their family members with advanced cancer. And the question was, do you want to be informed the truth about your cancer? And the dark bar is the patient and the light bar is the family. And patients overwhelmingly and family members said they did want to be informed the truth about the cancer. Where there was some difference between the patients and the family was on the right-hand side of the slide, is patients wanted to be informed immediately. Family members were okay with being sort of informed more gradually about sort of what to know, sort of the prognosis and the illness trajectory. Okay, let's now what I want us to think about is the sort of our next question. And because I think part of what we know is that patients feel like they're somewhat ambivalent when they're in the room, when we're in the room with them, right? So what percentage of seriously ill patients do you think will report wanting their clinicians to be honest? So let's select one for this next polling question. Do you think patients report wanting their clinicians, what percentage? 50% want their report wanting their clinicians to be honest, 75%, 90%, 100%. What do you think? They, do they really want us to be honest? Do they not? And how ambivalent are they? Okay, it looks like we've got some good results here. So we have 50%, we have 3% of people are saying that 50%, 12% saying 75%, 57% saying 90% of patients want their clinicians to be honest, and 29% saying that 100% of patients. Okay. So let's go. This is from Jean Kuttner's work, which she did a survey of patients, and on 100% of these serious ill patients said they wanted their doctors to be honest. But then she asked them another question that I'm going to poll you about. And the next question was, do you want your clinicians to be hopeful? And what percentage do you think said they wanted their clinicians to be hopeful? Now, honest and hopeful. So 50, 75%, 90%, 100%. What do you think? Because this is the thing, balancing honesty and being hopeful. What do people think? Because this is where you can feel in a jam when you're in the room with the patient. Okay, it looks like we've got some good results. And our results are 50% of patients, only 3% of our respondents felt like was feeling right. 75%, 9% of our group, 90%, 13%, and 100%, 74%. Okay, so let's look at the answer here. So, and in fact, what percentage of patients want their doctors to be optimistic? 91%. Right, so this is in fact the tricky piece when you're sitting in the room with the patient, is that we feel like they want us to be honest and they want us to be hopeful. And I remember when I was a fellow at the Farber and a patient said this to me, and I said, you know, like, what if I have information that is like honest, but it's not hopeful? And I remember thinking, I just must be not bright enough to know how to do this, right? That there must be some way to thread the needle, and that this became a really tricky thing to figure out how do you do both. So I think that's part of what we're going to talk about in this cognitive model. So let's talk about the amount of time it takes to actually talk about prognosis. So I would say it's a myth that everybody worries it takes too long. I would say the truth is it is a skill, but it's a skill that can be learned. So discussions about serious illness in the primary care setting, non-experts, it takes about a little over 5 minutes. What we notice the big difference is that the physician talks most of the time. There's little exploration of the patient's values, and there's much more of a focus on procedures. Experts, on the other hand, it is longer, but it's not an hour. You know, it's a little under 15 minutes. They let the patient talk much of the time. It's much more focused on the patient's goals, and it's more partnership. It's more of a partnership related to the treatment decisions. All right, so let's talk just briefly about prognosis and patient coping. So I think the key piece in this is that the cultivation of prognostic awareness is a process, and it happens over time, over multiple visits. This isn't going to be something that happens in one fell swoop. It happens over time. I think that patients, when we're trying to help them cope with serious illness, actually have two main tasks. One is to understand the likely trajectory of their illness, and the second is to understand their prognosis and life expectancy. And the tricky thing is they have to do this both cognitively and emotionally, right? And this takes time. And I think, you know, one example I give is there was a young patient who I took care of during my fellowship who was a young man named David. And if you caught him, he had metastatic pancreatic cancer. He was in his 20s. And if you caught him on a day when he was planning his funeral, he looked like he had it all wrapped up. He knew which mass, which priest he wanted to say his mass, what music he wanted. If you caught him on a day he was grieving the fact that he was never going to be a father, he looked like he had no understanding of his illness at all, right? He would demand that he was going to be cured, and he could not make sense of it at all. And so I think the key piece is that there are some pieces of this illness that emotionally people may not ever come to terms with, he cognitively could make perfect sense of as much as any 20-year-old could that he was going to die from this illness. But emotionally, there were some things that never sort of made sense to him about the trajectory of his illness and what to expect. So I think when we think about how patients make sense of illness over time, we kind of think about, instead of them being in denial or not in denial, as it being much more like a swinging pendulum between less realistic hopes and more realistic hopes. So I think early on in illness, we'll hear patients say things like, you know, I've always been lucky. I think I know it's only a 5% chance that I'll beat this, but I've always been lucky. Why not me? And then as people integrate their prognosis more, we hear them say things like, you know, I just think maybe I'll take that vacation to Europe this summer with my family because why not? Maybe I'll just do that. That makes sense, right? So it's subtle. It's a subtle shift, but we hear them understanding that time isn't unlimited anymore. And I think that's what we see as people slowly begin to integrate their prognosis over time. And we call this sort of a middle space of knowing, right, that there's this impossibility of living with the awareness of their terminality every minute of every day. I say to patients, it's perfectly normal and healthy to have times that you forget. You know, so Avery Weissman was a psychiatrist here at MGH who did lots of work trying to understand how patients with cancer cope with their illness. And I think he would talk about the patient David, who I just spoke about, that, you know, David had some middle space of knowing, right? He could integrate the fact that he was going to die, but he could never integrate the fact that he wasn't going to be a father. And that was just normal and natural, right? And that didn't mean he was crazy or he was in denial. But you can imagine how hard that was, because if his oncologist saw him on the day he was demanding to bank sperm, he would call me and say, Vicki, he's in denial. It's crazy. And then I saw him that next same day, and he was talking about his funeral, and I was like, I think we're fine, right? But part of this is understanding that both things are true and real, and understanding that it's okay, but this is just what it looks like to fully cope and live with an intolerable reality of being that young and living with your illness. So let's just talk about this cognitive model about providing prognostic information. I think that we start with assessing the desire for prognostic information using ask, tell, ask, communicate the prognosis kindly. We'll talk about pairing hope and worry. Identify the emotion, the affect, name and respond to it. Using the I wish statement, hope for things that are possible, and also concluding with a plan. So when we talk about this, we talk about providing prognostic information to help patients make informed medical decisions. And what I think about in the times I've truly gotten thrown out of a patient room is when I've answered the wrong prognostic information to question, right? So patients typically ask for two different kinds of prognostic information, either, hey, how much time do I have left, or what is going to happen to me in this illness? And both questions give some kind of prognostic information, but I'm going to answer the questions differently, and I need to know which question I'm answering. So a really useful tool is Tony Bach's Ask, Tell, Ask, which he's written about extensively in JCO, and he's got a great website which is called Vital Talk, which I encourage you to look at. And so the ask part of the Ask, Tell, Ask is assessing what they really want to know. How would this be helpful to you? What do you really want to know? Like, are you asking about time? Are you asking about function? It avoids giving too much information, and it allows an honest discussion at the level of what the patient needs. So for the patient who wants to know life expectancy, I use a standard method to provide prognostic information, usually some length of time that gives me some sort of wiggle room, because we are uncertain and inaccurate. So days to weeks, weeks to months, months to years. For patients who want to know what the future will look like, often they don't know what it will be like to live and die from a terminal illness. They're often surprised that the decline is slow, and they want us to tell them what the trajectory will look like, right? They have no idea that what it looks like to live with and die with Parkinson's or ALS if they've never been around someone who had that illness. And it's our job to help them make sense of that and understand what that will look like, so they can plan. So when we do give prognostic information, we find that pairing hope and worry can be helpful. And so that same patient, David, I asked him, I said, David, what if I have prognostic information to give you, but I don't think it's very hopeful, but I do think it's honest? And he said to me, Vicki, well, I just want to know that you hope I would be the person who would beat it. Not that you know I would be, but that you hope I would be, that you care about me and that you hope I would. And I said to myself, I can genuinely be on that hope train. That feels really genuine to me. And so that sort of informed where this hope-worry technique comes from for me. And so we use this to inform both making a prognostic disclosure about time and about function. So I may say something like, I hope that you do well for a long time. At the same time, I worry that that time could be as short as a few months. I hope that you regain some function in your legs. At the same time, I worry that you may not. I think what's important about this is it acknowledges the uncertainty, it aligns with the patient, and it also allows you to be honest about the prognosis. I have to say recently there was a clinician who, it was actually a physician, who I had this discussion with, and he asked me how long I thought he had to live, and he asked for a prognostic disclosure, and I made it, and I really thought he had weeks to live. And he had a delayed response to chemotherapy. He lived months longer. He came into clinic to see me, and I said, hey, not for nothing, but I was really wrong. Like, what did you think about that? I was so wrong. And he said, well, Vicki, you said you hoped you would be wrong, and you were. And I thought, well, I certainly did. And so I thought, you know, the reality is this feels like a very genuine way, and even when I've totally messed up and I've been wrong, it's worked out that way as well, because I did hope I was wrong, and I was. So I think the next piece when you're giving prognostic information is to expect that there's going to be emotion. And so that when you give prognostic information, expect that there's going to be sadness, anger, or disbelief of some kind. And I think the key piece is, what do you do when the emotion comes up? And I would say this is where I see clinicians struggling. And the common pitfalls are there's reassurance, there's offering unhelpful treatments, they take back what was said. I've seen clinicians, I saw one clinician one time say, well, maybe the CT scan reading was wrong. I'll go downstairs and talk with the radiologist myself, right? It's just because the emotion was too hard to manage. So I think the key piece is, I always say to people is, expect there's going to be emotion and think ahead of time about how you're going to respond to it. And I think we need to name the emotion and let the patient know we heard it. So something like, I can only imagine how sad this is to hear. I think the I wish statement can be really helpful. Tony Bach also has a great paper on this. It's a strategy for using genuine empathy without taking back prognostic information. So I often say, I wish I had different news, and then I'm just quiet. I just sit on my hands and I'm quiet, and I use silence. And I let the patient integrate the information because they need time to process it because it's so challenging. And then I think we do need to talk about hope, but we need to talk about hope for things that can be honestly supported. I'm hoping that we can get you feeling better so you can spend some good time with your son, or whatever the thing is that you think can actually be honestly supported, not something that you think isn't honest, because that just doesn't feel okay to us as clinicians. So let's just recap this model. So assess what information patients want. Sometimes they want to know time, sometimes they want to know function, sometimes they just want to know, am I going to make it to the summer or to graduation? If you're going to give information, do it in a way that pairs hope and worry. It helps deal with the uncertainty and it communicates that prognosis kindly. Expect emotion and plan how you're going to respond to it. Help them hope for things that are possible and conclude with a plan. I would say we all care for patients who are seriously ill, and this is part of our job as healers. So treat the suffering when you see it, whether it's physical, psychological, existential. provide a sense of control and dignity for patients, prepare the patient and family so that they can do the work they need to do. Find your own language to talk about these difficult topics. I gave you some suggestions today, but you need to make this your own, right? You need to find a way to adapt this language so it works for you. Avoid prolongation of dying. Patients want to live when they're living, but they don't want us to prolong an uncomfortable dying phase, right? They want us to help them live when they're still living. And also, I think, don't try to do this alone. It is too difficult to do this alone. And if you can, have a team. Have a team or a buddy or somebody else to be able to do this together because it's too hard. This work is too hard to do alone. So thank you so much, and I am happy to take questions.
All right. Thank you, Vicki. That was fantastic and just really rich, and I'm so glad that you've given us links that we're going to put on our website. We have a number of questions, but before we begin, I just want to remind you to our audience, if you have a question you'd like to submit, you may still do so. Just type your questions into the questions pane, and we'll answer as many as we can. So the first question is, how do you work with families who do not or cannot make any decisions? They're sort of, I guess the idea is sort of people are flummoxed.
Well, I think that is tricky. And I think, you know, the issue is sometimes that, you know, sometimes families can't make decisions because we are asking them to make decisions. We are not making recommendations. And I think on that slide that I had earlier on, we need to make recommendations when we can. And part of the reasons people can't make decisions sometimes is because we are giving them way too many choices. So I think when we can, we need to really give them two reasonable choices, if at all possible. I think if somebody can't really make decisions at all, then they're not really a good decision maker. And the question is there somebody else who is a more appropriate decision maker? Beth, how do you think about that?
It's interesting, Vicki. You know, a lot of the time, what comes to mind for me is families who can't make decisions. I mean, when the patient can't make a decision, it's really all about, I think, values and goals clarification. You know, what's important to you at this time in your life. When families can't make a decision, the thing I think that has been so hard is to help people think about, you know, it's not the family's decision. And one of the most helpful things somebody taught me was to say something like, let's just imagine that your loved one was sitting in a chair right here with us right now and could speak for him or herself. What would he or she say about what they wanted in such circumstances? Because it really takes the onus off of the family. They're being asked to speak the patient's voice.
That's a great point.
Instead of making a life or death decision for a loved one, which is really, really tough.
That's a great point.
And Beth and Vicki, this segues right into a second question, which is how do you communicate unwelcome news when family members instruct you not to tell the patient a serious diagnosis?
Mm.
Yeah, I mean, you know, this happens often in it's not only in cultural settings where people have different cultural values than we do, but often. And I feel like part of this is our job is to really respect what the patient's wishes are. And so often what I will do is, with the patient and the family member present, is say to the patient, what would you, if related to your medical treatment, how would you like us to manage your medical information? Would you like to know everything? Would you like us just to talk to your son or your daughter or your decision maker? How would you like us to manage this? Because then if the patient says to me, I want you to talk to my son, I don't want to know any of this, then I have my answer. If they say to me in front of the son, no, I want to know everything, then the son has seen that I've gotten my marching orders from the patient. How do you handle it, Beth?
No, I completely agree with you, Vicki. That's exactly what I would have said.
It helps to provide some structure. I love it. This is great. Okay, what empowering questions can patients and families ask to enable patients to receive palliative care and hospice care sooner?
I mean, I think, you know, part of it is finding out what your resources are in your area. And I think, you know, some of this is coaching patients about how to be able to just say, I want a referral. Or sometimes patients don't even need a referral and can just ask for it themselves. I certainly have patients who self-refer into our clinic. I think, you know, one of the things that we did a lot of work here with early on is coaching. Our clinicians wanted to refer patients to us. They were just afraid to do it. They didn't know the language to use to talk to the patient about it. So we did a lot of work giving language for the clinicians in the beginning, and now it just rolls off their tongue, most of them. And that was helpful because they were nervous. They didn't want the patient to think they were giving up on them. And now what's funny is that they say, oh, I love my patient. Will you come see this patient? So now they see it as a special thing for their patients, not something to be dreaded. So I think it just becomes, the culture shift takes time, is my sense.
Yeah. Very good, very good. And how do you enhance the congruency in a team's approach to these difficult conversations so that everyone is sending the patient the same message, a similar message?
I mean, I think related to, you know, internally within our palliative care team, we do a lot, you know, with our team meetings. We talk about these things in our approach a lot. We do a lot of joint meetings with oncology, with our cardiology colleagues, so everyone is aware that we're having this, you know, that we're all singing the same song. And we do, you know, before I make a prognostic disclosure to one of the cardiology or the oncology patients or the cardiology patients, I check to make sure, if I don't know that prognosis, I check in with the oncologist to make sure that I've got that prognosis right. And that's quite helpful, so we're all on the same page. The last thing I would want is to be providing prognostic information that is incorrect. And that's been the best way for us to be all coming together. And I think, frankly, the oncologists have appreciated having another place to think this through with the patients because it's difficult and it's very isolating work often. So I think you just have to talk about it. Nothing, you can't give short shrift to finding a place just to talk about it for 5 minutes about what do you think is going to happen with this patient in the next month or 2 months or 5 months.
Excellent. And Beth, do you want to comment on that?
Yeah, no, I was just thinking again about meetings in the intensive care unit where often the patient, him or herself, is usually not part of this meeting, so you're really talking about this with the family. And I think something that's been really effective and helpful is to have a team meeting before the family meeting so you can hash out your own beliefs because, you know, not everybody agrees about what to do.
Right.
So trying to help people manage their own emotions on the team or disagreement or conflict before you go into a family meeting so it doesn't surface there is, I think, really important.
Oh, it's critical. I mean, you have to be very clear and have a united front because it is completely unfair to a family in distress for us not to be very clear about what we're recommending.
Yeah, I think that's important. And, you know, I think, Vicki, how do you deal with the fact that there's so much handovers, you know, so not everybody is aware necessarily or isn't on the same page because there may be an intensivist, there may be a hospitalist, everybody's sort of talking about different things. There's not always good ways of communicating a consistent message, even amongst the healthcare professionals in the team. How do you handle that?
Yeah, it's really interesting. We've gotten to the point now where we write all of this in our notes, where meaning that we write prognostic awareness, the patient's prognostic awareness in our notes. We write what prognostic disclosure was made. We write the clinical team's prognostic assessment, whether that was related to the patient and family, what the reaction was. All of what I talked about today in this talk, we put in the medical record. in the palliative care notes. Because otherwise, where is it, right? Like all this stuff with the handoffs, the poor hospitalists or house staff, how are they going to know? Did anyone talk to the family about X, Y, or Z, and how are they feeling about it? So,
just out of curiosity, do you have a special place in your electronic record where you house this particular information?
Well,
we in the conference notes.
We do, in fact, but then because we are going to Epic, it all went away.
Okay.
So, yes, but it will be coming back as we built a platform because I think it's really important that every health system have, we call it one source of truth.
Right.
Because otherwise it's impossible to find.
Yes, exactly. It's really tough.
And on that note, I'm sorry, guys, but we are out of time. I do think this is wonderful that we've ended on the subject of communication, which is what this is all about, and it's fantastic. I just want to thank Beth and Vicki Jackson for sharing your expertise and insights with us, as well as everyone in the audience for setting aside time in your busy day to participate. We hope that you'll join us for upcoming programs in the Schwartz Center for Compassionate Care webinar series, including Bridging Differences in Power with Respect, which is on March 17th, and you can keep up an eye out for our invitation emails. Please visit the www.theschwartzcenter.org for program details and learn more about the Schwartz Center for Compassionate Healthcare. We know how busy you are, and we very much appreciate your taking a moment to complete the electronic survey upon exiting today's program, and we truly value your input, including ideas for future webinars. And Vicki, I want to thank you particularly. Beth, thank you so much, and everyone have a great day.
Yeah.